Hello, everyone, and welcome to the Ask the Expert session, which is in our new, slightly different format, which is a panel discussion. This is where instead of having a presentation on a subject, we gather together various experts and have a discussion. So today I am joined by three experts in the world of transitional care. Transitional care is when someone transitions from or moves from pediatric childhood care in the healthcare system to adult care and how that process is handled and how it is navigated. I'm going to say up front that there is no set way that every hospital in the UK will follow. So that's why I've made sure we've got three separate people who've gone through three different processes, and hopefully that give us a bit of a jumping off point for the discussion. I'm going to quickly introduce the panel, and then I got a few other things to say. We've got Dr. Joshi. He's a transplant hepatologist. I can't say that word. He's a transplant hepatologist from King's College Hospital in London. We've got Sarah Small. She's a parent of someone who's got PSC, and we've got Max Lewis, who is a person with PSC who's been through transitional care himself. None of these people have any connection to each other. So Dr. Joshi works in London, Max had his care in Oxford, and Sarah, her child's care was in Edinburgh. So hopefully this will allow them all to be very candid about the process they went through without worrying that they're going to insult their doctor or insult their own child or something like that. I'm going to try and use as inclusive language as I can when I'm going through this, parents and carers. But if we do only say parent or carer, please understand that the feeling behind that is meant to be inclusive. And I have also let everyone know that this subject could be quite personal. These are personal stories, and the participants know that they don't have to answer specific questions if they don't want to. So that might occur, in which case we're just going to move on. A nice little segue into questions. You can ask questions in this session. If you're using the Zoom app or on your phone or on the desktop, there should be a little Q&A button just at the bottom in the middle of the screen. You can click that. You can submit your own question anonymously or with your name. And what's new this time, because Martin figured it out at the last session, was that you can upvote questions. So we'll know which questions are the most wanted to be asked. So that's a lot of introduction. So I'm going to pass on over. Hopefully, if we could just go around and introduce ourselves, maybe give a little bit of background about yourself and so on. We'll start with let's for the introductions. We'll start with Max first. Let's do that.
Yeah, hi, I'm Max, as mentioned, and so I am 22, so fairly recently come out of the transitional care. I was diagnosed in 2016, along with ulcerative colitis as well, and then when was it 2020, I then had a stoma operation. And that's been the case until now, and I'll have the second operation to make it permanent in the summer of this year. And throughout, yes, I've had PSC alongside the UC. And to begin with, I went to hospital with jaundice, um, and severe itching and all of those symptoms, and then eventually settled on the fact that it was PSC. They managed to slowly come under control through kind of, I presume, I have no idea the medical background as to why they came under control. I was on ursodeoxycholic acid, which I'm no longer on. And then when I had the stoma operation, not with no medical expertise behind this, but my liver results were completely changed, and I've had stable liver results since that operation in 2020, touch wood. So that's where I'm at the moment. So yes.
Excellent. I was quite a sort of urgent start, and now it's kind of in a nice lull. I like that. We move over to Sarah, if that's okay.
Yeah, of course. So I'm a parent, and my son, Charlie, was diagnosed in 2021. So it was kind of during COVID. He first got diagnosed with Crohn's in the April, and that was found through colonoscopy. He'd been experiencing sort of periodic stomach cramps and sickness, very random. I was just keeping a diary of it, and I just thought, this isn't right. Got some blood tests at the doctors, and they repeated them because the liver functions were so high that they repeated them. But Crohn's was what was diagnosed first of all. And then in the June, so 2 months later, he was diagnosed after I think it was an MRCP he had. And because of COVID, it was a phone call that I got to confirm the diagnosis. And I know a lot of other people have had similar experiences just because of the timing. So of course I just went into panic mode, and I had felt like I had nobody to speak to initially, and just crumbled and Googled and all the wrong things. Um, so he was 16 at diagnosis. He's now 20. And there was a change in our hospitals that the transitional age from children to adult services used to be, I think it's now 16, but when Charlie was transitioning, it was still 18. So he actually had a good couple of years under the children's care before transitioning onto the adult services. So in a way, I'm grateful that we had the children's services, just because obviously it's a completely, having the two experiences, it's, you're very much involved, and, you know, we got given a lot of information directed at us, and whereas now in the adult team it's obviously very much directed at Charlie, and we get to ask questions and we get to go to all these appointments and things, obviously, but it's just that change. He's fairly stable at the moment. He's had periods of jaundice in the past, but generally speaking, again, like Max, touch wood, he's doing well.
Excellent.
It has the odd, sort of flare, I would say, with the Crohn's, stomach cramps, that type of thing. But generally, the consultants are happy with his liver results any time that he's in clinic. So, yeah, that's kind of his backstory.
Excellent. That's good news that he's stable at the moment as well. That's good.
Yes.
We got two stable people. I like that. You also touched on a comment that I've got on my own notes, which is about the age at which transitional care happens. So we might loop back to that later. If I could go over to Dr. Joshi now, maybe you could give us an introduction to yourself and your hospital, and maybe give us an overview of how it works at your hospital. And I just want to make sure that it's at that hospital specifically.
Yeah, thank you, Mark. Really nice to hear from Max and Sarah as well about their journey. So yeah, I'm based at King's College Hospital, which is in South London. And we're quite unique in that we have paediatrics on the same site as adult services. So I work quite closely with the adult, with the paediatric team. I provide some of their endoscopies. The way it works at King's is that at 12, a lot of young adults or patients and their families will start to enter the sort of pre-transition service. So this is just sort of sowing the seed, starting to sort of work on some of the key principles that transition is based upon. And one of the key principles is self-management. So it's about providing that information to the individual, but also the family as well. And then slowly, making sure that they understand the differences between pediatric services and adult services. And then at 16, they can enter the sort of full transition service. And we've called it the young adult service because transition can mean a lot of different things. It's sort of can be quite confusing. And we want this to be a positive experience. So we've sort of identified and we did some work with some of our sort of patient groups to say that we should be calling them young adults. And then obviously then they can move to adult services. So it starts at 16. And we sort of changed the age limit a little bit. It was 25 at one point. It's sort of more towards 22, 23. But what it means is that we're not set on a specific age group. So obviously, if your hospital is at a different site, there is a sort of absolute hard cutoff. But at King's, we can be a little bit sort of easy or liberal with that. And it's about making sure that the individual is ready as well. Now, I look after adult patients with PSC, sort of very involved with their care, their endoscopies. We obviously sort of have a clinical trial portfolio as well. So they meet me potentially at 16. They may have met me earlier because I do ERCPs for the pediatric group as well. And then there is that relationship, or maybe that familiar face that it's sort of they sort of see. But yeah, it's about just starting the process and then seeing what the needs are for that individual and also for the family as well. So we're quite relaxed, but you can imagine there are sort of pressures because more patients are coming through, but it's about when they're ready. So yeah, that's how we do it at King's anyway.
Makes sense. If we the question on age is an interesting one. I never went through any sort of transitional care, so I'm curious to know is Sarah mentioned 16 and 18. You mentioned that it can go on a little bit longer and it starts earlier. So is there a kind of mandated national age at which you become an adult in the NHS's eyes, or is it a bit more fluid?
So what I would say is, again, it depends on the trust and the hospital at which you're based at. So, for example, I know some hospitals have a dedicated adolescent or young adult ward. So that could be from 16 up to the ages of 22, 23, but it really depends. We don't have that at King's. I think we would really benefit from that because, at 16, you're in some centers, you'll still be seen as pediatrics, and at 16 you're very different than for example, a 6-year-old, and your needs are very different, so it really depends. I think we need to be better at sort of supporting young adults because their needs are so different to adults, and in the same sort of way, having a 17-year-old next to maybe a 70 or 80-year-old is very sort of different as well and may not be appropriate. So it's about recognizing the young adult as having their own needs, and then trying to sort of adapt the environment. And obviously, we're talking about sort of inpatients, but even outpatients as well. So you just have to be a bit fluid, but it's according to your local trust. And some people will say 16, you go to adults, whilst again, some hospitals will have dedicated wards and sort of places for those individuals.
Sort of an interstitial age range, I guess. Max, I think you mentioned that you were diagnosed quite young, at least with the colitis Crohn's side of it. So does that match? Does what Joshi has said sort of match your experience that you were sort of weaned into the adult care, or did you find a kind of straight cut off? Or I'd love to hear your thoughts on that.
So when I got to 18, there was a straight cut off. But it's the period before that, definitely, as mentioned, 16 to 18 was definitely a period of transitional stuff. My pediatric consultant who was my consultant for both of my illnesses came with me to my first couple of adult appointments with each of my consultants in the adult wards.
Oh wow.
When I was about 16. And then I stayed with pediatrics whilst having one or two, it's all a bit blurry now, but I had one or two appointments with the adult side at the same time as my pediatric sides, but my pediatric consultant was still in charge until 18. And I think that definitely helped. I think the experience that I had was that my consultant in pediatrics spoke directly to me with my parents there in my appointments, which I think really helped me. I don't know from a parent's point of view, but from my side of things, to cope with the transition of taking responsibility a bit for yourself with your illness, it definitely helped from that. And he started doing that from even before 16. Which I found very helpful. That's not to say that inevitably when my mum had a lot of questions, etc., he'd completely speak to her. But from my side of things, it was nice that the initial part of a consultation or appointment was always kind of me and my consultant to begin with, and then it would kind of broaden out to my parents as well. And that definitely was a pro of my transition. I do agree though with the young, just quickly talking about when you're at 17 suddenly being next to, say, a 70-year-old. I think that for me that was the biggest shock of going into just going into the outpatient ward in with the adult team was going in and suddenly being the youngest in the room and going into a full liver clinic where people have got lots of different liver illnesses, and it was kind of quite a shock, very busy and complete age range, and that was the biggest shock to begin with. But I got used to it.
Yeah, I think we're nothing if not adaptable, I think is a good phrase. And Sarah, was that a similar process? I know your son was diagnosed at 16, I think you said, if my notes are correct. So yeah, did that vary because you maybe came into that process potentially a little bit later?
To be honest, what Max has just said, it kind of echoes our journey as well, more or less. So, you know, we attend these appointments and the consultants and IBD nurses and things, because Charlie's condition in the Sick Children's Hospital in Edinburgh, it was the same consultant who dealt with his IBD and the liver. So it was one consultant we were seeing, and we had the IBD nurses that always attended as well. So they would very much, you know, speak to Charlie, and me and his dad would be in the room as well. And Charlie to this day still like gives me a row for asking too many questions. And I'm like, well, I'm sorry, I'll never stop asking questions. But so like Max was saying, you know, they speak to the patient and then, you know, turn to mum and dad, do you have any questions? Because, well, Matt, I can only speak for my son, but he didn't really ever have any questions when they said, have you got any questions to ask? And of course, at that age, not very often did he have a question. But I would always have something to ask. So our transition started, I think, maybe after his 17th birthday. We had, so the liver team is very close to the Sick Children's Hospital, but the IBD hospital is about 40 minutes away. So we've got two separate hospitals that we need to attend for the different illnesses. And for the transition period, the first transition visit, the consultant for IBD at the Western General Hospital in Edinburgh, him and an IBD nurse came to the sick kids and, like what Max has said, sat in the room with the children's consultant, the paediatric consultant, and, you know, just kind of softly introduced themselves and this is what to expect. And then it was a good few months later, his second transition appointment was at the other hospital for IBD at the Western General, but his IBD nurse and consultant from the sick kids attended that appointment as well. So we were really grateful for that approach, because that was one of my questions actually to the paediatric consultant of, when Charlie becomes an adult and he goes into adult services, what will that look like? But again, like Max has said, at the age of 18, you know, you're in adult services, you've had that transition. And at 18, that's the cut-off for us as well. So he now deals with the liver team in the Royal Infirmary of Edinburgh and the Western General for his IBD. So it's two separate hospitals, but so far, touch wood, obviously the communication between the two has been amazing when we've needed it. Because again, that was a question I had and a bit of a worry of, it's two different hospitals, will you all speak to each other? And I know things are now electronic these days, you know, with the technology and things, but that was a huge worry for me. And again, as Max said, being a mum and losing a bit of control, because it would be me that would phone the help desk to just, I don't know, change an appointment or query something or ask a question. Charlie had the number as well, and he was well within his rights to want to phone it as well if he needed to. But mum did take control of his care. And to a degree, because he works some night shift work, he's an apprentice electrician, and just because of his job and the hours that he does, the consultant in the liver team in Edinburgh have taken Charlie's authority. For me, I can speak to them, because obviously it's difficult if he's sleeping for a bit during the day and I need to phone and change an appointment, or they need to phone about something, they will speak with me, which is very, very helpful, and I'm really grateful for that as well. So I think the loss of control from a parent side is really difficult to adapt to, but I would say you do get there and you get better as time goes on, and you just readjust. constantly reminding them, have you, because now you get a lot of appointments, not by the post, but you get it through this portal. And I just actually asked him the other day, have you had any messages about any upcoming appointments? But I have to say, he is I'm lucky that he's very switched on with things. He wouldn't just ignore a message. He would, he wouldn't not attend. He's sensible, and he's looking after himself. But it's just not having that control of a letter coming and addressed to me and being able to, and that's just the the reality of them getting older and needing to take that responsibility on.
And I suppose that's the big elephant in the room of this discussion, is that the loss of control that a parent has over the health of their own child as their child grows up. And that must be a very hard thing to do. Like you've just explained, that there is an element of letting go but still being involved. But I imagine from a doctor's point of view, that's quite a hard thing to manage as well, because you've got two audiences, one of whom is having to take more control and one of which is going to have to give it up.
In adult services, full adults, most people may come with a partner or a spouse. They can still come with their mum, they can still come with a sibling. But I think obviously I'm not a pediatrician, I'm an adult doctor as well. So I remember when I first started, you are there, and like you said, Max, I would always talk to the individual, the individual who'd come for their appointment, and I would say, we're going to talk. And maybe that was just my sort of approach. And then what I would always say is, mum, dad, or whoever was there, then we can talk. And then it might be that the young adult has got loads of questions, or maybe they don't have any questions, like Sarah saying her son was, and that's okay. But then you shift focus and you talk to mum, you talk to dad, and you go through things. And the way, and again, we are lucky because we have everything on one site. So the geography thing you can't take away. It's really important because going to a brand new place, it doesn't matter whether you're going to a hospital appointment or to a new, like, sort of holiday destination or something. Going somewhere new is always a little bit sort of, there's a bit of anxiety, car parking, where is something. But I suppose we have that on our side. But what we always do is, as we get to know the individual, the next time I'll always say to mom or dad, next time maybe they will, the young adult will come in by themselves first, we'll have a chat, and then I'll call you in. And that way it gives, the sort of family, the caregivers, the parents, that opportunity to let go a little bit, but they're still involved with everything. And that's the key thing. You can't exclude them. And anybody who thinks they can is going about it the wrong way. And in the same way, you wouldn't exclude a sibling, a partner, a husband, a wife, whatever. So they're just there because they care, and that's very important. But you have to give both sets of sort of individuals or teams the time to answer their questions as well.
That makes sense. I'm gonna go to Max in a minute, but if you indulge me a little story, is when I first got referred to Birmingham for a transplant assessment, my mum took me. I needed a lift there. My mum took me, so I was 27 at the time. Oh gosh, she was older than me, let's put it like that. And she sat there, and I remember in the waiting room sitting there and going, I want to go in on my own. This is quite. And then the lovely Dr. Ferguson came out from Birmingham and went, Mark, you're coming in, and said, oh, is this your mum? I said, yes, it's my mum. And he said to her, would you like to come in? Instantly, my mum was like, yes, and already walking for the door. So I feel, at least my experience is, it must be quite hard for a parent to let go. And I've never been in that position, so I'm not going to speak on that, but I thought that was quite interesting. But I wondered if Max...
Can I make a comment? So James Ferguson obviously works in a young adult transition service. So he's very aware of what the expectations may be of the person who's come with them. And at 27, Mark, you're still very, very young. And
okay.
You can probably read mum's face. And she was saying, I need to be in there. So
yeah.
No.
Ultimately, it was fine, but I just thought it was quite... Oh, it was quite... She was on her way to the door before I'd even got up. But I was wondering if Max, have you had to be firm with your parents at any point, or have they I mean this in a nice way, but sort of quite gracefully step back. And of course, feel free to say you don't want to answer this.
No, honestly, I know yes, it's a difficult one because, well, I like to think that I've got a bit of empathy for, well, particularly my mum on this stuff, where she's always very much, wants to be there at every appointment, even if I've just got to go in for a blood test, etc. And that was very much like with them obviously becoming an adult, where for the big appointments, obviously, I would love it if she comes along, and she does. But then for kind of smaller stuff, whether it's a few tests here and there, etc., yes, I'm often, especially the fact that I'm now living away from home as well, so I'm not actually with her, so we'd both be traveling into Oxford from completely different parts.
Yeah.
I just kind of said to her, and been a bit firm, you're not going to make a difference here. These are a few tests, a few whatever. I'm just going in now and I'm doing them, and we're getting it done. And then for the bigger appointments, or the at the yearly checkup, etc., then I'll say come along. But even then, maybe I'm a bit too firm, and sometimes she'll pass me a note with loads of questions in.
Yeah, to take.
Like, make sure you ask these.
Yeah, but that, or a text message, right? I've seen it where
Sorry?
and I'll say, "Oh, is mum or dad coming?" And then they go, "Yeah, no," and then they open their phone and it's like, "But I've got these questions." I was like, "Of course," and that's just as important. So,
I know, and it's
So
funny.
it's definitely
No, on you go,
no.
Max. Sorry.
you go on, Max.
I know. I think it was a quick story was my most recent appointment a couple of months ago for my yearly checkup, and yes, we're both coming from different places, and I said, look, I'll be fine for this one. I know what I'd had my scans, etc., and I knew the results of them, and they were all okay. So I just said, look, I'm going in. We've got no questions really. I'm sure she did have questions, and then I had a text saying I'm on my way, as I was in the waiting room. I was there an hour early. I got called in early, and then I had a knock on the door whilst I was in the appointment, and then it was like, well, of course I said no, come in, etc. And then she still had some questions, of course. But it's definitely yes, it's an interesting one to manage as a patient, as a young adult, trying to kind of stay empathetic to well, in my case, my mother, but at the but also trying to kind of take control a bit of your own health.
It's that balance, right, Max? And obviously, as a clinician, I would never make that decision for the young adult. And I would always say, you need to go away, discuss how do you want to do this. If you want to both keep coming, that's fine. But if you want to sort of, where, you come in first, young adult comes in first, and then parent, again, it's what works for you, and you adapt. But it's just that balance, and sort of going forward, who can make the appointment even sometimes. So, but it's just that ability to adapt.
Yeah, Max again is sounding very like my son. And in the last maybe, so he's 20 just passed, and I would say for about the last year, when he first told me this statement, I just about knocked him over, because he said, "It's fine, Mum, I don't need you to come, I'll just go myself." And I couldn't believe what I was hearing, and I was in total shock. And it was a routine clinic appointment, like Max said, it was just for bloods. But the fact that I wasn't going to be there, and I thought, right, I just need to let him go. I don't want to annoy him, and I don't want to do something against his will. But I then take, when you reflect back and you think, I'm proud that he wants to go into some of these appointments on his own. And that's when he had said, he went, "Oh, Mum, you just asked too many questions." But I did say to him, maybe 2 or 3 appointments ago, I said, "Now, you do know that there will be times that I will need to come to some of these appointments for you, another pair of ears." And he's like, I know that. But like Max said, for the blood tests, maybe the odd ultrasound, things like that, there's no benefit to me really to be there, and he wants to do it himself. And I've got better. The more he's done it on his own, it's still you still want to go, but you respect that they want to kind of take the lead themselves and be there for the more meaningful appointments, I would say, is kind of how I've tried to balance it. That, okay, I'm not needed to this one or the next one, but he knows that I'm available at any appointments that he wants me to go to, but more so the more meaningful discussions.
In terms of logistics of the age and becoming responsible for your own healthcare, because Sarah, you were talking about booking appointments on behalf of your son just because of schedules. Is that something that the now young adult has to agree to? Or is like I'm thinking of all the medical dramas where someone suddenly becomes 18 or 16 and suddenly the parents have no information and no access to information and hospitals refuse to talk to them. I don't know if that's a thing made up for TV dramas, or whether there is something slightly equivalent, and whether the new young adults would need to have an arrangement in place. Maybe Dr. Joshi can speak to that.
Yeah, I think you do have to agree these parameters, because at 18, that individual is an adult, and their letters will be sent to them. We have obviously an electronic system at King's. The individual is recommended to register with it, and everything is sent, and they can access their letters, their reports, everything. But at 18 it is that individual. But if you agree, or if it's stated that mum still wants, like Sarah's still able to do, then that's fine as well. And I suppose it's again just deciding who is going to be available. Sometimes the young adult is very busy with other things, and if they're well, then that's good. And sort of things like appointments, prescriptions, all of those things, that's all part of the transition sort of process as well, where if the young adult is moved away from home, then who is going to be responsible. And that's what we work on in transition, and that's all part of the principles of self-management, which even some adults are horrendous at. Okay, let's be honest. Okay, they forget their appointments, they don't renew their prescriptions, all of these things. So it's just about giving them the resources to do that successfully. I think technology is good, it's better. Obviously there's lots of problems with it as well, but yeah, it is down to the sort of agreed sort of policy within the hospital, but also amongst the parent, caregiver, and the young adult.
That makes sense. And I like that seems to be built into the process, that those discussions happen, which is very useful. It's slightly less dramatic than the TV shows make it out to seem. So that's
everything
good.
is less dramatic, I promise.
We've had a question, which I'm going to slightly abstract away to not give away any information. But the question is they've got a child who's currently in child services, and they're going to be aging into young adulthood soon, and they've had all of the colonoscopies in young child services under general anaesthetic, and now they're moving into adult or young adult services, and that isn't the standard there. And obviously the child is quite worried about that. Is there a way to have that continue on for a transition period, or what is the sort of process around that?
Yeah, I can help try and answer that. So obviously there's a lot of differences between pediatrics and adults, and one of them can be at endoscopies, the provision of general anesthetic. So the way we do it at King's is we can offer general anesthetic or propofol, which is the drug. So they may not be sort of completely asleep, but they'll get a very strong drug and they'll essentially be out of it. And that would be propofol. And then what we do is we sort of build in the sort of possibilities that the next time maybe we can try it not under general anesthetic, but sort of heavier sedation with an anesthetist present. So the safety aspect is always maintained. And then bit by bit, we sort of, see if it is possible. Now, some people can't, or some people are unable to have it without a GA. And I think most hospitals these days can adapt, or I'd like to think they can adapt. And if they can't, then there'll be other hospitals nearby, or we all work within networks that you can support that individual. And again, that goes the same for adults as well. Some adults cannot tolerate endoscopies without general anesthetic. So there's ways around that. I don't think that's impossible in the modern day.
of the people here, Max might have had some experience of making that transition. Are you okay to talk about that?
Yeah. No, completely. I remember there's no, I haven't had it without sedation because there's no way. Um, so yes, my adult team have been great, and I've had not general anesthetic, but I've had heavy sedation for two colonoscopies since I've been in adult care. So yeah.
Yeah, it's good that there's provision there. One of the questions I had written down when I was thinking about this earlier was, obviously not all hospitals know about PSC or have specialists about PSC. Not all hospitals even have liver specialists, hepatologists. So if there is a parent out there with a child who might not be under a PSC specialist, might just be under a regular hepatologist at their centre, Dr. Joshi, would you recommend they think about trying to transfer to a hospital with specialists to aid in the transition, or do you feel that maybe that isn't needed unless they're at a specific stage of the disease, maybe?
Yeah, I suppose it's sort of the individual's needs first of all. So, if they've got knowing a team, sort of growing up with a team, or having been transitioned to a local team, and then you've got a good relationship, then where I sit, I would never try and break that, take that over. But I suppose the reasons for sometimes I get to see either young adults or adults with PSCs that maybe I can offer them something different. So one of them could be a clinical trial, and we would support them, or maybe they do need an endoscopy, whether it's a colonoscopy under general anesthetics, for example, or an ERCP. So what I then tend to do is I work with that local team, because again, traveling into King's, there's no parking. I can tell you now, there never will be. And it's a pain. So if you still have your local team, you can still have us, and then what we do is we share the care. And they may see me once a year, but they see their local team in between. So they have their local team, and then they have me as well, should they ever need me for anything more. But I think it's about teamwork, and centers will always work in teams, because that's the only way we can deliver effective healthcare.
That makes perfect sense. Thank you. We I can't believe we've been online for 40 minutes, so I've got a few more rapid fire questions. There's a magic wand question, which is on a podcast I listened to by a friend of mine. But if you had a magic wand, so you don't need to worry about resourcing it or costing it, what one thing would you change or improve about transitional care? If we start with maybe Sarah first and go around, I love it as a question because it's pie in the sky. What would make things infinitely better?
I think having that in between area for young people to be, like we were saying earlier, like not because they're too old to be in a children's ward and children's waiting rooms, but yet they're too young in one way to be with the older generations as well. So I think if every sort of main hospital had an area for, say, your 16 to 25 or whatever that age may look like, I think that to me sounds that would have been so welcomed. And I think from people that I've spoken to just generally, and hearing Max as well, I think having something like that would actually be really, really helpful. But like you say, it's a magic wand. If we did that, that would be great. That's what I would choose.
That's a good answer, I think. Max?
It's good. This going to sound very boring, but I'm going to echo the same, because I do think it's the biggest thing that I think this isn't, transitional care, to have a transitional area, whether that's physical or even just in terms of when you're having checkups, whether the clinics are, young person's clinics, where it's not a clinic for all different ages again. So even if it's not a physical space, but a physical space would be very nice.
Yeah.
But yeah, from whether it's from yes, 16 to 25 or 18 to 25, whatever it is. I don't know, whatever the age is, but that kind of bracket I do think is, yes, it is a transitional bracket. So
yeah. It's a very unique period of life as well that you can group 16 to 25 is a period of maybe an interesting fact is I was at a talk in America about transitional care, and they have transitional care up to at the age of 28 because that's when young adults will age off of their parents' insurance and have to have their own, which I thought was quite a long time to be in this process. Dr. Joshi, what would you do? The same thing, or
I think recognizing the young adult as their individual identity and age group, yes. I think what's very important of transitional care in general is the holistic approach. So, I would argue that half the time I don't do as much as some of my other colleagues. So we have a social worker, we have a psychologist, we have a youth worker, and what they provide sometimes when it's not about physical, is sort of their physical health, it's their sort of holistic health, it's their mental health, and having that embedded within a transition service is there in most services, but it does fall away as you enter adult services. And certainly smaller hospitals may struggle with that. But I think if I could take anything, I would continue that sort of holistic approach, that holistic sort of support, which everybody needs, and certainly anybody with any ill health, and have that accessible for everyone.
That's great. And with infinite resources, we can do that. That's a brilliant thing to do. I got one final question for Max and Sarah. If anyone else who is listening does have any questions, you can send them. There's a Q&A button, and we do have some time for that. But if I go to Max first, my question was, if you bumped into a PSC patient who was 14 and just about to start this process, would you have a sort of a key hack for them or a key takeaway to make the process as easy as possible for them, having been through it yourself?
I think from one side where you may have consultants speaking to you directly from that age, etc., or starting to, I think from a patient side is to start being proactive in kind of taking not interest, that's the wrong word, but taking well, I suppose interest in your illness, into really understanding it, trying to ask more questions in consultations and come up with them yourselves and with your parents, etc. And be the one to start asking, even if you're asking them on behalf of your parents, because I think that it just starts to give you a bit more confidence of in your own abilities to manage your health. And again, not straight away from 14, but just slowly doing it from 14 and until you fully transition to adult care.
I love that idea of asking questions on behalf of your parents. So your parents are the ones who've kind of gone, this is something we need to know about, but having that go through you and your own language, I think would be very empowering. That's a great suggestion.
I think one of the biggest things is confidence to, when you are 14 and talking to a consultant who seems, is very senior to you, can be quite a daunting experience. So I think even if, yes, you're not making the questions, just starting to ask the questions just instills some confidence for future appointments.
Excellent. And Sarah, obviously a similar question to you, but if you were to meet a parent of someone who was about to start going through this process, what would your sort of top advice be to that parent?
Probably to try and not panic, because that's what I did, and take a step back and allow the child to start, like Max said, take little steps to independence, but you're there in the background, but just to try and take a step back, as hard as that is, but you're still there, you're still hearing the information, you're still able to ask questions, but to let your child, I know I was guilty probably of maybe not, especially in the early days, maybe not giving my son the opportunity to ask, because I knew he wouldn't, but I was right in there because I was desperate to ask X, Y, or Z. So I think, looking back, I probably should have taken a step back, but I couldn't because I was just in that, fraught, panicked state.
Yeah.
And wished I'd dealt with things slightly calmer. And just to reach out for any help that, with the PSC support page, as I mentioned to you earlier, Mark, is a lifesaver. And I've met a couple of mums local to me through this page who've both got children, and we meet up for coffee and, just being able to share. But if you can't do that face to face, just having that support online on the Facebook page is amazing. And never ever be alone, and not think that you've got any help or support at hand. It's important to talk and ask and just share experiences, but try not to panic. And it does get easier as the older they get as well. And I can say that now, but it's 16. I couldn't see that, but I can now. So
yeah,
it's just time and getting the balance right, and it's hard, but
I understand. There's definitely power in finding people in the same situation as you,
yeah.
and it's something that when you get diagnosed with PSC or your child gets diagnosed with PSC, it's very easy to feel very alone because of how rare the disease is. So finding your tribe, to sort of steal a phrase from other communities, I think is a very important thing to do. And Dr. Joshi, maybe finally from you, what would your top advice be to either a parent or a patient going through transition?
Yeah, I think everybody's sort of journey is very individual. I think when it comes to PSC, the PSC support have got lots of information. I always say there's lots of information, lots of safe information, and it's reliable. And through that, you can find, peer support for your child, for the young adult, or for yourself as a parent. Okay, and I think that's just as important. Again, a lot of hospitals now offer like peer mentors, where we have young adults. It may not be with PSC, but they have a chronic liver illness, and they can talk to the individual about their journey, and there may be some similarities, and there may be lots of things that are different, but sometimes people want to hear it, sometimes people don't want to hear it, but just knowing that there are these sort of options available, and that goes for families as well. But I always say, with the likes of the PSC support, they will help you. And if you're unhappy with anything that maybe you've been told or the experience that you're having, the digital world via the NHS, via sort of hospitals can be accessed, and people are there to help. So don't sort of suffer in silence, to steal a phrase as well. But just reach out, and I think there's lots of individuals who'll be there to support the young adult, but also the family and the sort of parents, caregivers as well.
Thank you very much. We've been talking for about 50 minutes, which has gone incredibly fast, if you ask me. So I do want to say thank you to all three of you for joining me today. And I know this is a slightly different to our usual Ask the Expert, but I do like this format for topics like this. I think it's very useful. I've got a few things to say, if you'll indulge me for a bit. We do have a leaflet about explaining PSC to children, or for a child to read themselves. It's here it is. It's kind of got a slightly comic booky style. Actually, Joshi helped us write this.
I've got mine here as well.
You got to see they're everywhere already, but you can order them for free from our website. That might be of use to you or your child if you want it. It, like I say, it is free. Again, I want to say thank you to Sarah and thank you to Max for sharing your stories. I know these are quite personal stories, so I really do appreciate you coming on board. And thank you, Dr. Joshi, for giving up your time to come and talk to us, and just being wonderful and sharing your knowledge.